Good afternoon, and welcome to our session, Innovation Ignited. Aspen Health Innovator Fellows reveal what no one else will. I'm Margaret Lapiz, and I'm a member of the second cohort of the Health Innovators Fellowship, a relatively new program that the Aspen Institute launched in partnership with Greenville Health System, the largest not-for-profit healthcare system in South Carolina. The purpose of our fellowship program is to strengthen the leadership of innovators across the healthcare ecosystem and inspire them to create new approaches to improve the health and well-being of all Americans. The second cohort is comprised of 21 leaders from across healthcare. We're a diverse group of visionaries, entrepreneurs, and innovators, representing different settings and sections within healthcare. Through this fellowship experience, we're challenged to contemplate what it means to each of us to lead with values in our respective roles, and what it means to step up to have a greater impact in healthcare in a way that is consistent with our values. This marriage of values-based leadership and a commitment to using our entrepreneurial skills and instincts to tackle healthcare challenges, along with the courage to do so, is the common thread that runs throughout the fellowship. On behalf of the Health Innovators Fellows, several who are here with us today, I'd like to thank Rima Cohen, Managing Director of the program, for all that she has done to connect, inspire, and challenge each of us. I know my fellow health innovators are incredibly grateful to her for this experience, and for me it has been one of the great blessings and high points of my life. Okay, in this session, you will be hearing from 4 Health Innovators Fellows. We will be using the Ignite Talk format developed by Brady Forrest. It's 20 slides, each slide automatically advancing every 15 seconds, 5 minutes in total. After the 4 presentations, we will open things up for any questions you have of us. And with that, I'm pleased to introduce the first of our speakers, Dr. Sonia Angell. Sonia is a Deputy Commissioner at the New York City Department of Health and Mental Hygiene and oversees the agency's Division of Prevention and Primary Care. The title of her talk, and what no one else is saying in healthcare, is that technology is a social determinant of health.
So in the 1930s, an appraiser assessing the neighborhood of Bed-Stuy in Brooklyn included in his report under detrimental influences, obsolescence and poor upkeep, and infiltration of Negroes. Across the United States at this time, the government ordered similar assessments across hundreds of neighborhoods. Later called redlining, those neighborhoods demarcated in red were deemed dangerous for underwriting mortgages. Those neighborhoods were largely poor communities of color. The investments decreased, and it affected much more than just housing. It affected jobs, it affected security and safety, and it affected food. It affected those things that influence health. The social determinants of health are things like housing, jobs, income. They're the things in our environment where we live, work, and play that affect health outcomes. But what about technology? You know, we talk about it as tools. We talk about it as other items that help us with health, but we don't talk about it as a determinant of health. There are 2 things that helped me here. Thinking about first science explaining the natural world, and technology, however, develops and explains the human-made world. If we think of it that way, maybe technology is a determinant of health. I'm going to talk about just one area of technology because it is so huge. I'm going to focus on technology that's about collecting information and disseminating information. So big data we also often think of. So who benefits from big data? You have to, just like bingo, you have to be present to win, right? So if you are in big data and people like you are in big data, then it's more likely that its derivatives are going to serve you. But how do you kind of get in big data? So let's just think about a few examples. There are many, but one might be you use the internet frequently, or you go to the doctor and your health record gets uploaded, or you take a little swab from your mouth and you send it off, and there you go. Your genome now is in big data. Frequent touches of you and people like you create what I'm going to call your digital fingerprint. And if you've got your digital fingerprints all over the data, then you're in business, right? Because then ultimately those derivatives are going to use your information and create things that serve you. Those derivatives include things like apps, algorithms, breakthrough therapies, all things that we consider important to advancing health. Okay, so let's talk about how you get into one of these, the internet, for example. Okay. Yeah, right? Now, imagine that. What if that was your norm? The dropped line. How often would you go to the internet? How often would you go touch it, exchange information, send emails? Not very frequently. In fact, 10% of Americans live in these dark blue areas, areas that don't have broadband access, and broadband access is an indicator of good access to internet. Looks a little bit like redlining, right? 55 million Americans. Some states are introducing work requirements for adults on Medicaid to stay on Medicaid, and they have to enter that information online. And yet 1/3 of adult Medicaid participants don't use a computer or have internet. What does that mean for their ongoing access to health care? In New York City, 20% of Latinos don't have insurance. That means it's harder to go to the doctor, and it's less likely that their health information will go in. And yet precision medicine, one of the greatest investments that we have right now, relies upon this information to develop breakthroughs and opportunities. What about genomics, right? We're going to cure the incurable. The best genomic database is the one that's most diverse, and yet overwhelmingly our databases are made up of people of European origin, those with the least diversity. The result is ultimately the amounts of studies that we have going on these databases are far outpaced by assessing those with backgrounds of European descent, leaving other groups wholly underrepresented. What will this mean for products that will serve them? So I've told you just a few ways in which technology shapes our world. The way in which it both serves us but also can amplify and introduce inequities. Technology is a social determinant of health, but we made it so we can change it. We can make underrepresented databases representative. We can include the excluded. We can test the structures of technology to assure that they don't advance inequities and, in fact, support equity for all. The right to life, liberty, and the pursuit of happiness is a huge thing to deliver, and frankly, we cannot do it without health. If we call out technology as a social determinant of health, we empower us to use it to address inequities, and yeah, maybe we can achieve this for everyone. Thank you.
Thank you, Sonia. Our next speaker is Ricardo Rivera-Cardona. He is the Chief Business Development Officer for Somos Community Care in New York City. Prior to assuming that role, he was in charge of the Medicaid program for Puerto Rico from 2013 to 2016, which managed 1.6 million lives, 50% of the population of Puerto Rico. He is also the past president of a Puerto Rico health plan, a role he held for 5 years. His Ignite talk is Building a Resilient Healthcare System, Lessons Learned After Hurricane Maria.
A health worker crosses a river after a 12-hour shift to handle the issues of her family, sleep, and then go back to work next day. That's just one example of the stories in the aftermath of Hurricane Maria. Maria was the most destructive hurricane in Puerto Rico's history, leaving the entire 3.4 million people without electricity, water, and communications. The storm found an ally of devastation in the weak infrastructure of the island, infrastructure that for decades have not received the necessary investments to keep up with times. In addition, this coupled with the recession that has been going on over 12 years, a government in bankruptcy, and an underfunded healthcare system created a perfect recipe for devastation. My wife and children got trapped in the island for 12 days before we could get together, and I was stuck in New York. And as we got back together in New York, my organization saw the devastation in the island and appointed me to lead relief efforts. The healthcare system was decimated, and the needed help was taking a long time to get to the rural municipalities away from San Juan, affecting more than 2.5 million people. Therefore, we adopted a hard-to-access region in the mountains, and we set up pop-up clinics, and we provided food and supplies and served thousands amidst chaos and uncertainty. And this provided me a window to see what was not working. I saw that the root cause of the shortages of products and services was due to the absence of electricity. Most of the health facilities were running on generators. However, diesel and gasoline was extremely hard to get. In addition, state and federal agencies failed to convey the real needs of the population, and that explained mismatches like receiving winter jackets and ski boots for people that live on a tropical island. I also observed how overwhelmed all agencies were in handling the magnitude of the devastation. They were not prepared, and it took them a lot of time to overcome the power struggles between them. For example, right after the storm, FEMA prohibited any movement of any container from the San Juan port. So the consequence, some of the aid that was sent from the States never got to the people. So the food and everything rotted at the port. What's more, most organizations sending aid forgot to incentivize the local economy. They sent armies of people and supplies instead of using local services and products as they became available. Additionally, some relief efforts unintentionally replaced existing local services, delaying the recovery time. For example, local physicians were not able to invoice as services were being provided by physicians coming from abroad. So here is what I propose. First, it is critical for the healthcare system to move to renewable and smart energy. After all, Puerto Rico is a tropical island with sunny, warm weather all year long. Second, we need to have redundant communication systems to effectively convey the population needs. From a primitive approach, like radio communication systems, to a more sophisticated approaches like satellite-based systems. Third, health institutions need to create a well-thought, integrated disaster recovery plans, incorporating all the federal and local agencies for emergency response, not to leave behind the community. Then demonstrate all the employees to ensure that when an emergency happens, they do not start improvising or going around disorganized like chickens with their heads chopped off. And last but not least, I also propose that the health sector works together to develop a centralized technological platform which will allow all health providers throughout the island to input their needs, including manpower. Additionally, the platform will facilitate the coordination and distribution of relief efforts to meet the existing needs of institutions across the island. This will prevent the saturation of aid in certain regions and overlooking others. So certainly we do not control the possibility of another disaster. However, we do control the steps we take in order to minimize its impact. So we need to hurry up because we are already in the middle of a new hurricane season. Thank you very much.
Thank you, Ricardo. Cathy Kenworthy is a business person who has spent the last decade of her career in healthcare and previously in financial services. She most recently was president and CEO of Interactive Health, a company hired by employers to improve the health of their employees, and is on the eve of a new assignment as COO of the Ounce of Prevention, an organization dedicated to strong care programs, policy, and research that improves the lives of young children born into poverty. Her Ignite talk is Moneyball, a way to improve healthcare in the United States.
Thanks, Margaret. I am so excited to be here today to talk to you about Chicago, baseball, money, and definitely how we can use all those things to improve healthcare. So we're going to start by bringing to mind a very famous icon, somebody that we all know and love, Gordon Gekko. Gordon said, greed is good, greed is clarifying, greed is a way of getting through very complicated problems, and he talked specifically about the role of information being the most valuable commodity that we can zero in on. So when we think about information in the healthcare setting, we know that the US is unfortunately a terrible outlier when we think about the amount of money we spend and the terrible impact that we don't see on life expectancy. In fact, on this one chart, we can see that the US sits all alone on its own off here to the right, spending almost $10,000 currently per capita, compared with actually a diminishing life expectancy in the US compared with all of these other countries. Translated to a family of 4, we spend today 3 times more on health insurance than we did at the turn of the century. And when we think about this expenditure of healthcare compared to every other household expense, we can see that we're spending today double what we spent in 1960, outpacing the rate of growth of every other household expenditure but for the cost of college. Further, when we take this and we think about the impact on our economy, we know that we are consuming 18% of our GDP on healthcare dollars. By the way, I might point out half of that is what many other countries spend, 9% in total, to provide universal care to all of their citizens. So, what to do about this very serious and complex issue? Well, I know what you're thinking, right? It's just like the Chicago Cubs. And the Chicago Cubs spent a phenomenal amount of money over many, many years to get actually not very good performance, in fact, performance that was getting worse. So we turn to another icon, Billy Beane, famously played by Brad Pitt, who said, there's a different question. Do you believe in this thing? And what I think Billy really meant is, of the money we do have, what is the very best way of spending it? Billy answered this question with 3 basic ideas. First, zero in on impact. He looked at on-base percentage. Second, rank the players based on that value. Figure out which players can get on base. Third, spend money, but spend it smart. Spend it to drive that metric. Oh my gosh, is now the time to mention the Chicago Cubs did win the World Series? In 2016, they spent, by the way, half the money that the New York Yankees did. So they applied these ideas to good effect. So the question is, are they relevant to healthcare? And the American Medical Association, while they didn't call it Moneyball, I believe said the answer is yes and hell yes. Let me tell you more. First of all, the US healthcare system has an incredible silver lining, which is a fantastic array of innovation over many decades. That is an enormous strength of our healthcare system compared to others. In fact, sometimes generating more innovation than other countries combined. However, that innovation comes online with no requirement that any given innovation is better than the existing protocol. And so that's led to a head-spinning array of confusion, whether the topic be nutrition, genetic testing, what constitutes a preventive care exam. And so if we boil down the ideas of Moneyball to healthcare, there's 3 ways we can think about it. Let's zero in on the information we do have. Let's really assess new innovations, and let's line up returns and risks so that it makes more sense. So when we think about our players on the field, here are the players that we know drive impact. They involve emotional health. They involve maternal and early childhood health, a field I'm about to get more into. Gun proliferation, mistakes in healthcare systems, all could be based on understandable and credible information, and then we look at that information to evaluate verified benefit compared to cost. We can look at these incredible examples, EHR, Theranos, where that analysis clearly wasn't done or it wasn't done well. Further, we can use the techniques of financial engineering to separate what's an A-rated bond from a C-rated bond and ensure that C-rated bonds, while there's money to be spent on those, don't crowd out A-rated bonds, i.e. places where money can be spent, low impact, high impact, low effort to get there. I want to share one quick example of an A-rated example, prediabetes, #1 health risk in the US. Many people don't know that they have it. $15 of additional expense, $84 of verified benefit across a population of 100,000 individuals. So my fastball to you is the US healthcare system is innovative, but it's not effective. Better ideas do exist in that greedy private sector. We can apply them through the idea of Moneyball by better rating through some kind of clearinghouse and spending the money we do have better. Thank you so much.
We are now going to make the transition from money to sex. Dr. Stacy Lindau is the founder and chief innovation officer of NowPow, a social enterprise IT company, and president of MapsCore, a community asset mapping organization. She's also a professor and gynecologist at the University of Chicago, who has studied sexuality in the context of aging and disease for more than 2 decades. Her Ignite talk will enlighten us about the vaginal muscle that no one is talking about.
At the University of Chicago, we have disavowed trigger warnings, but here in Aspen, I've seen some kids, so I'm just warning you now. Vagina, penis, dildo, bulbocavernosus, they're going to be said here to tell you what you need to know about this important muscle. In Chicago, we love our architecture. This is called the Cranes Communication Building, but affectionately known as the Vagina Building. The truth about the Vagina Building is it's obviously not a vagina, it's a vulva. The vagina is the inner canal. The vulva is the outer structures. The most amazing thing about this lady is obviously not her vulva, but her yoga pose gives us an understanding so we can agree on what anatomic region we're talking about today. It's a very interesting region with hair, skin, fat, and muscles. And the bulbocavernosus is a great muscle to know about. All of us in the room know about the anal sphincter. We use it hopefully once a day, maybe not at altitude, but the muscle around the opening to the vagina works a lot like the anal sphincter. To use the anal sphincter, you have to bear down a little. And a sphincter muscle is not just any muscle, it's a muscle that surrounds a bodily orifice and keeps it slightly closed. So did you know that people walking around with a vagina have it slightly closed in its normal state? If we want it to open, we have to do some things to entice it, let's say. So the resting state, the bulbocavernosus, is slightly closed. In the aroused and loving state, the bulbocavernosus is open. When the bulbocavernosus is not happy, it is contracted. And it can be very contracted and even spastic, and this condition is called vaginismus. In the loving, happy zebra condition, the bulbocavernosus is open and ready for business. The zebra being attacked by a lion is in fight or flight mode, and this muscle is hypercontracted. The most common cause of painful intercourse is too tight of a muscle. Women with this problem will say, it feels like my partner's hitting a wall this far in every time. And this is exactly the thickness of a spastic bulbocavernosus muscle. Most of my patients have cancer. The first thing they think is they have a tumor in their vagina, and they never do. Other women think I must have a congenital defect. Ignorance about this muscle causes suffering for men and women. Even girls who've unsuccessfully attempted a tampon, if they understood this muscle, would be suffering less. So there are a few things we can do about this problem. One thing not to do is to tell this muscle to relax. It really pisses this muscle off. And it gets even tighter. Just like you don't tell a spasm in your neck or back to relax. You've got to do something else. Now, a woman who wants to release this muscle, if she's given childbirth, she can think of pushing the baby out. If she hasn't, she can think herself a hen laying an egg. But what she shouldn't do is Kegel exercises. That strengthens this muscle. It tightens this muscle. And we've all been led to believe that Kegels are the solution to all pelvic problems. Now, here's another way to think about it. The simple act of threading a needle. And the point here is that sometimes the muscle's not the problem. Sometimes we have to focus on the thread. A floppy thread doesn't easily thread the needle. We have to twist it. We have to lick it. And as a patient of mine said, a marshmallow does not fit easily into a piggy bank. Now, marshmallows have their pleasurable aspects, but we never find them at a sex toy store, nor do we find floppy dildos. So it takes two for the ergonomics to work. I've done the largest national study on sex and aging, and as many as 40% of men develop erection problems as they age. Men need more foreplay as they age. So we have to have a firm erection. A floppy erection does not give this muscle the chance to release. In fact, sometimes it'll tense up. And a firm erection, but a tight muscle is also not a good combination. This can happen if a woman feels forced or pressured. It can happen if she's felt pain before. So for good ergonomics, we need a good firm erection, and we need some arousal. The woman needs to feel safe and loved, not under attack. Now, as women age, and actually sometimes on birth control pills, things can get dry down there. There are hundreds of lubricants on the market with thousands of chemicals that shouldn't go in your body. I'm a fan of coconut oil. You can cook with it, it works for oral sex, and it's a great lubricant. Some women need to retrain this muscle. And who knew that there were all these vaginal dilators out there? They come in all shapes and sizes. A vibrator or dildo works too. It's a device that can be used to gently stretch the muscle. You get a hand mirror, you get the dilator, and you bear down, don't contract up. Computer and commuter syndrome, I've named it that. This is a big problem in our society. Most of us sit all the time. We're sitting right on that muscle. It gets tight. And we're also cutting off the nerves and blood supply that we need for normal sensation. This is the opposite of yoga. This is physically and mentally stressful. I told you so much more about the bulbar cavernosus than anyone in the United States of America knows. But if you need more information, my lab has created Woman Lab to make sure all women and everyone who loves and cares for us has the evidence you need to know to work with the bulbar cavernosus and all the other parts. Now you're ambassadors. So when you need help in spreading the word about this exciting and important muscle, call me. Thank you so much.
I'd like to thank my fellow health innovators for their great presentations today. And as they take the stage, what we'd like to do now is open it up for any questions that you may have of us. And what we would ask is if you could briefly tell us who you are, and given the amount of time remaining, if you could just get to that question directly. Thank you. Yes. Thank you. We have a question here.
Hi, I'm Lauren Morell. I work for a company called Lantern. I have a question for Moneyball. One of the things, especially in behavioral health, Cathy, your actual name would be a good thing for me to use. Just gonna give you all nicknames for my question. My question is around behavioral health. So there's a lot of research out there. I know the Milliman study and the APA has looked into the impact of not integrating behavioral health into primary care and the additional costs that will incur for diabetes and other chronic conditions. But the problem that we run into quite frequently, and I'd be interested as to your thought, is how do you really tie behavioral health to an end result? Because even though people generally understand that that results in higher cost, a lot of organizations that we speak to are having trouble saying, well, how do we know it's definitely depression or definitely anxiety, definitely emotional well-being? And my worry in what you're constructing is that we would have the same issues where physical illness would be prioritized because there's more direct ties, and we would have the same issues of not funding behavioral health, which actually does have an impact on cost.
Great question. My colleagues may think I asked you to plant that, but the other example that I was going to share other than prediabetes is actually emotional health. So my prior company actually did work to measure emotional health, to measure identification of emotional health risk issues, to measure the improvement in emotional health, and actually to create a dollar value associated with it, which actually was higher in value than some of the physical health topics, including, in fact, prediabetes. So that's one answer. Your larger, I think, question is Moneyball could exclude things that aren't able to be quantified. I do want to be clear that while the example I used is a dollar ROI, I'm arguing that there can be a measurement of impact that doesn't always need to be a dollarized return, but an impact of some kind. And also that the system, I imagine, would simply risk rate. So things where it's very hard to discern impact, but it's believed to be there over a large scale, would just have a different kind of risk-return profile compared with something else that's very proven, and that get better democratized across all the different ideas that exist for how health, and I do mean health in total, can be improved. So thank you very much for the question.
I'm pretty loud.
They're
Okay.
So piggybacking on your question, one of the things, I was recently at a population health summit that Robert Wood Johnson helped put on that really encouraged us to stop thinking about only looking at disease outcomes when we're trying to improve the health of communities, but rather looking on the impacts that are creating those. And how, so things thinking of like transportation or a healthy food index, is there any way to incorporate those into the concept of Moneyball?
For sure. I mean, I did not elect to share, hey, here is an impact or Z metric or that kind of thing. I just think that the lesson of Moneyball was, you know, you can line up baseball aficionados across the room. I won't try to do it, you know, in terms of there's lots of different diversities of views about, you know, was on-base percentage the right thing, whatever. But they picked something, they focused on it. They evaluated decisions based on that and ultimately spent money based on that. And while I don't think it's the only answer to every complexity in healthcare, why would that be such a wrong idea to do a little bit more of that in healthcare?
Here you go. Hi, my name is Nikki Tyler. I'm from Washington, D.C., but I'm a Virgin Islander, a very proud one. And I think one of the things that a lot of folks don't know is pre-Maria, after the Virgin Islands had suffered the Category 5 Irma, it was the Puerto Ricans who day after day went back and forth between the islands to give us food and clothing. So huge thank you from a Virgin Islander. We affectionately call you the Puerto Rican Navy for all your help. And my question is more for those of us stateside who are from the Virgin Islands or from Puerto Rico. A lot of us obviously felt very helpless in terms of thinking about how to activate our communities and direct aid appropriately. So I'd love to hear your thoughts as someone who is on the ground after, where we can all plug in the holes if the federal government isn't fulfilling some of its potential needs.
Well, actually, one of the biggest frustrations that I had being in New York by the time the hurricane struck Puerto Rico was the fact that there was barely any communication, not to mention we were practically in the black here. So we didn't know what needs there were. We didn't know what was happening. I tried to call the office of the governor, the Department of Health, to see what was going on. Nobody picked the phones. They were completely overwhelmed. And basically, I ended up using my past influence. Since I ran Medicaid for 4 years, I knew all the physicians in the island and all the institutions. So I basically talked to them for them to tell me what were their needs. And then we made a list, we prioritized, and then we took the relief efforts to the island. So that's why I am advocating, and one of the ideas is for the healthcare to get together and create a platform in which they can all input the needs that they have so that people from the outside can look at that platform, can see which institutions across the island has the needs. So if I have medicines, then I can funnel those to the right places, because everybody, another thing that I saw was that in some places there were like 100 people trying to help, and then there were other places that needed more and there was nobody there. That's why we picked the mountains regions, but not because the government told us or we knew about it. It was because the physicians told us, listen, in the mountain regions there's a higher need. So if we have some visibility on what are the needs and where do they need those things, we can more effectively help the island.
I think what was really important is that you were a trusted agent. You weren't just an outsider who was concerned, but you were a trusted agent. And there's something to be said for that as well, sort of knowing who the trusted agents are on the outside in order to coordinate inside.
Yeah, I mean, it was a rough time, and they were running all over the place. And one of the things that I mentioned in my presentation was there was a lot of power struggles between the agencies. The federal agencies wanted to be in charge. The local agencies say, no, this is my territory, I want to be in charge. And then among the federal government agencies, they were competing also in who was in charge on what. And it was till months later that then the military took over, and then everything started to sink in a way that really helped the relief efforts to channel and to start impacting positively the island. So I sure hope so that it doesn't happen again, but if it does, that they have learned their lessons, yeah, and they can tackle the problem more organized.
Here you go.
My question's for Ricardo and Leffler. And my question is about, you said that the hurricane really amplified the infrastructure problems in Puerto Rico. And so my question is, hurricane season happens every year. And what do you think needs to change about Medicaid in terms of how it reimburses the federally qualified health centers, the comprehensive primary care network that serves many, many Medicaid patients in Puerto Rico?
Well, let me tell you one thing. Your question, even when it is very simple, is very convoluted because there's many things going on, and as you said, the hurricane just exacerbated what was happening. Just for everybody to be on the same plane, the Puerto Rico Medicaid program is not treated as the U.S. Medicaid program. We have a cap. It's a $3 billion program, and we only receive reimbursement for $300 million. So with the Affordable Care Act, that restriction was subsidized by additional monies that removed the cap, but not how can I say it? It didn't remove it, it just added more money so that you don't feel that. But that money is going to run out in 2 years. So with that, with the fact that the economic conditions of the island makes us serve half of the population. Medicaid represents half of the population services in healthcare. And in addition to that, due to the economic situation of the island, every health professional in the island earns at least 40, no more than 50% of what their counterparts earns in the States. So there's a lot of migration of health professionals to the States. So we have lack of access as well. So it's a very convoluted issue. And I think that looking into the future, we have to sit down, rethink how we provide a service before just raising a flag and say, we want more money. Fix it, rearrange the way we provide the system. It gives us the opportunity to innovate. And with that, then sit down with the federal government and say, okay, let's use Puerto Rico as an experiment ground in order to innovate and try something different.
There's a question up here.
I'm Donna Zarconi, also from Chicago, Go Cubs. But this is a question for Sonia. In Chicago, they've incorporated the Chicago Public Library system to become technology centers. So for those who don't have access to technology, there is access. I was intrigued by your presentation. How would you act upon it? What would you do to make it happen?
So technology is huge. So I'll just focus in on specifically this issue that you raised, which is access to be able to sort of use the internet to put information in and get information out in that way. One of the big challenges is that this history of disinvestment in communities has created an infrastructure that persistently remains inadequate relative to the communities that are in those areas. You mentioned Chicago, we have areas in New York City. This is not just an urban-rural issue, though it is true that in the rural areas the access is much worse. The challenge is that because of deregulation, there are also monopolies that exist. And so to overcome this, the quickest way to do it in urban areas is to look, and it's going to vary depending upon where you are, at what your opportunities might be, either for the government to assume the responsibility to provide it as a utility, or to purchase it and provide some sort of subsidy to communities so that those lower income communities can get access and at rates that are reasonable and allow them to. But there's not one answer that can address every individual community at this time unless the federal government steps up, recognizes that this is indeed a fourth utility, and really starts to look at the way the market is distributed, recognizing that there are some areas that will not be as profitable to invest in, and therefore the government is going to need to push investment into those areas to allow for that broadband access to be available more broadly. So there's not one simple answer, but at the federal level we could do something. Absent of that, every community is going to have to look at what is the best mix. But doing nothing is not the solution either.
One question here.
For Vulvalicious.
That's a mic drop right there.
I'm Nicola, I'm local. I wanted to ask if Kegels are not beneficial for enhancing sexual pleasure. I've always heard that.
Yeah, thank you. So let me explain. The 15 seconds didn't give enough time. So when people think generally about pelvic floor muscle dysfunction, women especially, the knee-jerk reaction is Kegel exercises, because we've only ever heard pelvic floor dysfunction and Kegel exercises together. So women can have pelvic floor weakness due to lax muscles. That's typically in women who've had multiple childbirths, or women with very heavy body weight, or other rare musculoskeletal conditions. The pelvic floor is weak because it's so lax. It's like a rubber band really stretched out. We can also have pelvic floor weakness in a high-toned state. So the muscles are so hypertonic, they're so spastic, they can't contract any further. And so the floor is weak and it doesn't have mobility, it's just in a contracted state. Kegel exercises are good for laxity before it's too lax, to strengthen the pelvic floor, which does help with sexual function. Kegel exercises are not helpful for that hypertonic, highly contracted pelvic floor. And so a lot of women who've tried for years for self-care before they come to see someone like me have actually done the wrong thing, because the public just hears pelvic floor problem, Kegel exercises. I hope that addresses your question. The other thing I'll say, because I know nobody else is, you're the brave soul who would ask the question, but let me just say, because I alluded to this, but it's really important. Some women come in and complain that they have no sensation down there. Like they don't feel anything. And they're worried that they have like a spinal cord injury or multiple sclerosis or undiagnosed diabetes. And the most common cause of that problem is hypertonicity of the pelvic floor muscles, including that vaginal sphincter muscle. Why does that cause a decrease in sensation? Well, small blood vessels and nerves have to traverse the muscle to get to the skin, which is where we feel sensation. And they're literally being strangulated. No blood flow, no oxygen. So arousal can't occur, sensation doesn't occur. Then the muscle just gets tighter because it feels like a failure from the beginning. So correction of pelvic floor muscle dysfunction with the help of a certified pelvic floor physical therapist. You can look her up on the American, or him up on the American Pelvic Floor Physical Therapy Association site, can restore not just the normal function of the muscles, but help women feel normal arousal and sensation again. People feel so helpless, and this just is such, for the most part, such a mechanical, correctable problem, and you're going to tell everyone you know.
My final question.
So this is also for Stacy. What you've done is really wonderful, but how do we make, as a society, women's health issues, and particularly women's sexual health issues, much more part of the conversation and socially acceptable? If it's a man's problem, they'll talk about it all day long, but it's different for women.
So thanks to Bob Dole, Senator Bob Dole, who did the first advertisement on TV for sildenafil, Viagra, during the Super Bowl. And when he did that ad, he tied his erectile dysfunction to his service as a Purple Heart winner, and as a military veteran, and to his prostate cancer. So to talk about male erectile dysfunction in our society, we needed a hero with cancer to get the conversation going. And then the pharmaceutical industry was wildly successful in bringing forth a whole array of drugs that have been very, very helpful. They help men and their partners, so we're all grateful for that. We've had no parallel success with drugs for women. A couple have come to market short of estrogen. None of them are worth anyone's time or money. And we haven't had a spokesperson. So scientists like me, and there are very few NIH-funded scientists who've been able to do NIH-funded research on female sexuality, I'm one of few, have demonstrated that men and women across the life course, across disease states, value their sexuality, regard it as a critical health issue, want doctors to talk about it, but we want doctors to bring it up. Actually, men and women both want doctors to bring it up. Doctors bring it up for men because doctors have a prescription for that. We don't bring it up for women because we don't know about bulbocavernosis, which would solve the 90% of the problems. That's an overstatement. It would solve a lot of the problems, and there's just not a simple solution, so it feels like a can of worms. My best offering is Woman Lab. So with a grant from the Jewish Women's Foundation, the LE Fund of the Jewish Women's Foundation of Metropolitan Chicago, we were given 2 years of time to put on the internet everything we know about women and sexual function, science-based. And what we've put there are every one of our patient education materials. We're putting out more all the time. We put out 10 questions to ask your doctor if you've been diagnosed with cancer before you choose your cancer treatment, 10 questions to ask your doctor about menopause. And we feel like putting these materials out with the University of Chicago and NIH-funded scientists, letting you print them and bring them to your doctor will hopefully facilitate the conversation. Thank you for the question.
Well, it's time to bring our session to an end. Thanks to all of you for joining us today. And kudos to Ricardo, Sonia, Stacy, and Cathy for their stimulating.